good afternoon, everybody, and a very warm welcome to the March meeting of the Integrated Care Board. Particular warm welcome to all the members of the general public who are joining us online today. Just a few announcements, if I can, before we get into the business. Staffordshire and Stoke-on-Trent Integrated Care Board meetings are meetings in public. They are not public meetings. And the meeting today is being recorded and will be available on the ICB website following the meeting. Could I ask that all cameras be off, with the exception for either my own camera or for those presenting during the course of the meeting? And make sure that microphones are on mute as well, please, because it will impact on the quality of the sound that we've got available. I will invite questions from any member of the public at the end of the meeting on any of the items that we've covered on today's agenda. So we'll come back to that, and I'll ask people to raise their hands on Team to direct questions via myself, if that is okay. Questions submitted by email in advance of the meeting will be addressed at the beginning of the meeting, and we'll pick those up in due course. So with those announcements said, we'll move into apologies if we can. We've got apologies noted from John Rouse, Neil Carr and Steve Grange is attending for Neil. Welcome, Steve, and thank you for attending. Pat Flaherty from the County Council, and great to see that Neil and Badwaja is attending. And again, Neil, and thank you for attending for Pat. Great to have you with us this afternoon. At enclosure 1, we've got the leadership compact, and board members will be aware it's a very important document that is used in all of our meetings, transacted by the ICB, and it guides the way that we conduct our business. We'll return to that at the end of the meeting just to check our compliance with that. Paul, can I just check with you that we are quorate and we're able to make the decisions that we need to make on the agenda this afternoon?
Yes, fully, David.
Thank you, Paul. And just to check that, are there any conflicts of interest in relation to items on the agenda other than those listed on the register that's with the papers? Okay, just pause. Thank you. So we'll move into the minutes if we can, of the meeting that were held on the 15th of February, and we'll take those first for accuracy and then any matters arising. So I'm grateful to Julie Holder for chairing the meeting on the 15th. Julie's on the call, and we'll just go through those for accuracy now. So just on page 1, Jill, can I just pick up a couple of items on the members' attendance? I'm ticked as attending on the 15th. I wasn't present at the meeting on that day. And also, can we just drop the interim by the title for Dr. Adiemo, please, as well on page 1? And then page 2. And then on page 3, just on 1, you'll note that I'm mentioned there as advising that it was a meeting held in public. I was not here to advise on that day, so it will be duly advised that it was a meeting being held in public. So if we could just make that amendment. And then page 3, page 4, page 5, page 6, 7, 8, 9, and 10. So can I just check, are there any other matters of accuracy or arising out of the minutes that anybody wants to raise? Okay, thank you. So in terms of the action tracker for that day, no items were brought forward for the meeting today. So that takes us neatly into item 6, Tracy, questions submitted by members of the public in advance of the meeting. And I understand that we have some questions from Mr. Ian Syme. Tracy, I think you're on mute. Thank you.
Thanks, Chair. I'll go through them in order and I'll stop at each question if that's okay. So the first question for Mr. Syme is acute care at home. Mention is made in the Finance and Performance Committee escalation report of workforce fragility within the acute care at home. I understand from NHS board papers that acute care at home has a 33% vacancy level at present. Any service having to carry that level of vacancies, even with maybe bank workforce input, most certainly cannot deliver envisaged services at requisite levels and will be at the very minimum overstretched. There are abundant examples nationally in the past that quality and safety of overstretched services can deteriorate rapidly. So first part of the question is, given the above, is there now enhanced monitoring of acute care at home service, very specifically as to the quality, safety and expected outcomes for patients? If so, could a flavour of such enhanced monitoring be given? And number two, what mitigations are being in action to reduce what is a serious vacancy level with the acute care at home provision?
Thanks, Ian, for the question. And Phil, I take it you're going to pick this question up, yeah?
Yes, thank you, Chair. I'll start off and then Mish may want to add on to the end as well, given the workforce support that's been put in place. So I've previously briefed the board on the operational challenges, as Mr. Symes has pointed out, in relation to delivery of the acute care at home service, which is particularly impacted over the winter period. Just before I go on to directly answer the question, I would like to stress, though, that the service is very highly regarded both regionally and has been recognised nationally. And in spite of the workforce pressures over the period of winter, across the West Midlands footprint, the service has dealt with the second highest number of calls from the ambulance service, which I think is a very positive thing to note. So it's a very, very dedicated, very valued team that we have there. So in terms of the first part of the question around enhanced monitoring, absolutely, we've got a number of steps. Some of them are new, which are in place. So the service has got a process in place for monitoring incidents. Management structure is in place, and in the last few weeks a new associate director role has been put in over the service to provide that additional leadership and oversight. There has also been a quality lead nurse appointed to support the service. Clinical excellence framework review has been undertaken by UH&M. On a daily basis, we monitor the service in terms of capacity and flow via our system coordination centre and through our system calls. We have an acute care at home board in place, which has membership from across the system, which works through the overall risks and delivery of the service. That then reports through into our UEC portfolio at a system level. Also, just to flag that there has been a specific risk relating to the acute care at home workforce position on the system risk register. Second part of the question, just in terms of the mitigations around workforce, I'll start off again. Like I say, Mish will pick up a number of things we put in place over winter to reduce that gap in terms of workforce. So firstly is the dedicated support from the People Hub, which has entailed a whole-time equivalent person based within that team to support mutual aid from across the system. We've also been using agency and bank staffing support, but obviously that has to be done on a proportionate basis to ensure we maintain quality and safety. We've also had GP Federation support, which has been really welcomed for elements of the service delivery as well. I'll pause there and just hand over to Mish.
Thanks, Phil. Welcome, Mish.
Thank you. Thanks, Phil. Thanks, David, and thank you for the question, Mr. Syme. Absolutely lots of work being done in the people space to support the improvement of that vacancy position. There has actually been an improvement to it this month because of recruitment, so we'll be able to update on that as we go. As mentioned, we have got the ICS people team supporting directly into the service, and what we've managed to create is a regular pool of bank and agency staff, so we do have that consistency where there are gaps to fill. And we've mentioned the GP Federation support, but we've also been able to appoint to a number of ACP vacancies, which is really positive, and just waiting for some staff to start. Some of the recent appointees are going to be working in a development capacity as well, so we're being able to grow our own in terms of our workforce plan there. The service has also recently established the Workforce Working Group, which will agree a medium and long-term action plan on how to attract and retain our staff. From a UH&M perspective, of course, as well, we're looking at the transformation of that service, and also how we can ensure that we can have a sustainable workforce. So thinking about how we utilise our wider workforce to make sure that we can sustain the workforce.
Thanks very much, Mish. Very full response there from Phil and yourself. Tracy.
Thank you, Chair. And the second question is around dentistry. It would seem that despite ring fencing Staffordshire and Stoke-on-Trent, ICB dental budget will be 9.9 million underspent in 23-24, which equates to a 14.9% underspend of the ICB's approximately 83 million dental budget. The dental underspend for all West Midlands ICBs 23-24 is around 50 million. The recent published dental recovery plan is very specific in that it will apply a firmer ring fence on NHS dentistry budgets for 24-25, so individual ICBs can seek to improve dental access. The dental recovery plan also highlights the guidance to support flexible local commissioning that was issued October the 9th, 2023. Mentioned within the ICB's joint forward plan in today's ICB paper seems to imply a West Midlands dental strategy. Number one, if there is to be a West Midlands dental strategy, how can it be assured that such is not a one-size-fits-all strategy, and that individuals' ICB's enhanced ring-fence budgets remain flexible enough in their dental commissioning to address their specific population's needs?
Thanks, Tracy. Welcome, Paul.
Thank you, David. Sorry, trying to get off mute. Thank you, Ian, for the questions. So I'll take them slightly separately. So the first one was about the Midlands dental strategy. We already have a national dental strategy, and we will have a West Midlands dental strategy produced shortly. Those provide the framework in which we can then look at our own plans. So we'll use those two strategies alongside the specific Staffordshire Stoke-on-Trent health equity audit, which we're expecting to be available imminently, and which has been done for every system, which allows us also to benchmark. And from the equity audit and the two strategies, we'll develop our own local implementation plan for our system. That'll take into consideration the National Dental Recovery Plan expectations and maximise the opportunities that it gives us for flexibility. We've very much recognised that there's a very clear national directive about a hard ring fence on dental budgets this next year, and we're going to work very closely with NHS England locally at West Midlands level to get the maximum flexibility we can within our budgets to align the budgets to the local implementation plan. So that was the sort of first one, Ian. And then the second one was about our local implementation plan. Will use that health equity audit to identify, set out plans to address the inequitable access where possible. We'll bring the plan through the ICB board when that's available, and we've committed to developing that plan in the first quarter of this financial year. So within that first quarter, you'll see brought to the board publicly the implementation plan, and then we will be bringing update plans through the board as we go through the year. So, David, I hope that answers the questions.
Thanks very much, Paul. Again, full response to Mr. Syme's question there. Tracy.
Yeah, that covers the second point as well, so it covers all his questions. Thank you.
Okay, Ian, thank you very much for again posing those very important questions to the board and for your attendance today. Okay, we'll move on, if we can, into item 7, the ICB Chair and Chief Executive update. I just wanted to pull out a number of things, not fully from the report, just a couple of announcements that I wanted to make. The first one in the report under 6.1 concerns our Chief Nursing and Therapies Officer, Heather Johnston. Heather, I just want to publicly affirm what's in the report. It's great to have you back, and it's also great that you've got such a solid team behind you who's managed your period of absence superbly. So I'd just like to place on record the board's thanks to Lynn Tolley and Becky Scullion for covering the role while you've been off, and it's great to see you back looking so well. So welcome back, Heather.
Thank you, Chair. Good to be back.
And the second point, I've already referred to this, but I just wanted to refer to it again at today's meeting. David Rogers, the chair at Combined Healthcare, is stepping down shortly after his long-standing relationship with Combined Healthcare. And I just wanted again to put on record my thanks and the board and systems thanks to David Rogers for all he's done to actually help to build a system-wide approach during David's time. So all the very best to David Rogers for the future, wherever it takes him. And importantly today, I just want to recognise a board member who it's his last board meeting today, Dr. Paddy Hannigan, our primary care partner member. Paddy, great to see you on screen there. Paddy, I just wanted to say a few words, if I could, just in terms of acknowledging your impact on the system. Over a 30-year period, over 30 years as a GP in the Stafford and surrounding areas, but also from 2013 until the establishment of the ICS, Paddy's clinical chair role of NHS Stafford and Surrounds Clinical Commissioning Group. And just want to note that for over a decade, Paddy has played a senior system leadership role as a board member, clinical leader, digital champion, and an outstanding clinical coordinator of particularly the COVID vaccination programme, but also other vaccination programmes linked to flu. And just from a personal perspective, you know, Paddy's ability to facilitate clinical collaboration, build trust amongst partner members, and his relentless championing of our patients has had a major impact upon the development and maturity of our system. So Paddy, on behalf of myself personally, but also on behalf of the board and the wider system, I just want to thank you for the leadership that you've brought. Very often in a very humble way, if I say it, not always seeking recognition for that significant impact that's been made, and to wish you all the very best for the future. I predict that you will not be languishing in retirement for long, Paddy. I think there'll be too much energy to bring back into other areas, but all the best, Paddy, and it's been great working with you.
Thanks, David. It's been a very short 30 years. It's flown by. It's been a pleasure.
Thank you. So with that said, Peter, can I hand over to you for any other exceptions you want to pick out of the report, recognising that we've got many of the issues on the agenda to pick up in a moment?
Yes, we have, David. So firstly, I'd like to second the praise that you've just given to both David Rogers and Paddy. I've written down professionalism and elder statesman, probably in relation to both, but particularly Paddy, and I'll remove the word elder and just say statesman. That's probably better, but a massive thank you to both for all their efforts. What do I want to touch on in terms of the report itself? Well, firstly, the health inequalities item. So the first item on the agenda, I think it's really important given the pressure that we in all systems are under right now from a UEC, from a financial and an operational point of view, to maintain focus on health inequalities and that wider left shift agenda, so that we have that ability to do the split screen piece that I do describe often when I talk about this kind of thing. So fantastic that you can see there in the report. We held the conference, the session recently, and from that we are finalising the inequalities strategy that I'm sure will bring through the board in due course. So really positive, and of course links to a lot of the recent narrative through things like the Hewitt report, that does remind us of the importance of focusing in that area. Now, having said all of that, later in the agenda, we've got a planning item for 24-25, and I think it's fair to say that you know, the narrative, the progress that we're making is gradual, but it is, as with all systems at this point in time in relation to 24-25, challenging, both from a financial, operational and a workforce point of view, and particularly triangulating all of the expectations on us as a system and making it all balanced. So it's a marathon, not a sprint, in relation to the recovery agenda. I think it's also important to acknowledge that we, as an ICB, are essentially tackling within that exercise, tackling the legacy challenges that we've essentially inherited from previous organisations. So it is difficult, it is really tough, but I'm hugely proud of the efforts that all system partners and many people within those partners have put in so far to build the plan to this point, but it is still work in progress. So I'll leave it there if that's okay, David, but happy to take any questions on any other items in the paper.
Thanks very much, Peter. So just pause there in case there are any points of clarification on anything Peter's just said or anything contained in the report. If not, we will receive the report and move into item 8, enclosure 6, NHSE Specialised Service Delegation. Welcome, Chris. You're going to take us through this, and the paper is quite complicated and quite detailed, and I understand you're going to take us through a presentation to bring out the salient points, and then we'll have an opportunity to seek clarification and assurance.
Indeed, thank you. Thank you, Chair. So I'll just try and share my screen, and as I do that, I will say that as usual when I'm sharing a screen, I perhaps lose sight of colleagues. So hopefully what you can see is a slide entitled Background. If someone could confirm that for me.
Got that, Chris?
Yeah, excellent. Thank you. So as I say, I will lose sight of colleagues perhaps. So if you just let me work through the slides, and I'll take them down, and then I'm happy to circle back to any issues and take questions and comments. So as you say, David, quite a significant item, and in keeping with other significant items we've put before the board, we have made the information we need to make available in the public board pack. There is then some reference material for further reading that's been circulated to board members in particular, and then in the board session itself we've got a short number of slides. There's about 9 in total that just seek to amplify particular elements. The first of which is that the decision before the board today is part of a national roadmap for the integration of specialised services with integrated care systems, and throughout 23-24 ICBs have been working with NHS England colleagues to co-design and co-produce many of the arrangements that are outlined in the board report today. That culminated in a total of 59 specialist services from a total of about 174. So some will be retained by NHS England. There are 59 which are detailed in the delegation agreement in the pack that you have, which are proposed for delegation. And in December 2023, NHS England board nationally have approved that the delegation can go ahead to 3 regions, of which the Midlands is one, and it's essentially that has triggered the proposals then that are before you today in some detail. So hopefully as I move my slides, they move on for colleagues at the board as well. So in terms of the benefits, we've been really keen to work with NHS England in articulating the benefits, and you can see they're kind of grouped around quality of care, equity of access and value. In the interest of time, I won't go through each and every detail within these slides, but they're there for colleagues to read as they're on the screen. Perhaps what I would say is that when you look at the 59 services that are in the delegation agreement, the vast majority of them have the word specialist before the nature of the service. So specialist cancer or specialist neonatal or specialist ophthalmology, for example. And essentially what that means is that there is a degree of complication and complexity with those services, but also that the ICB as the local commissioner commissions some elements of that pathway already. So the main benefit is essentially that the delegation gives local and local commissioners the ability to view the totality of those pathways in the round together with other ICBs in the Midlands region. So we can make essentially better decisions having all of that information available to us. I think, as ever with a kind of delegation question, there's then the subjects of, so what will be different? And in particular on the right hand side there, I've sought to amplify particular elements. So as with the pharmacy, ophthalmology and dentistry delegations we've considered previously, the accountability for services will remain with NHS England at national level, and the ICBs will take on the delegated commissioning responsibility. That means we will be fully responsible for decision making, and NHS England will have a seat at the table. We will also have full responsibility then for the relevant proportion of the specialist commissioning budget, and I'll talk a little bit more about that in a moment. But perhaps importantly for 24-25, the NHS England team will remain employed by NHS England. And there's then a collaborative agreement that's been made available as reference material, which articulates the relationship then between the ICBs and the decision it makes and the transaction of those decisions through the NHS England retained staff. I said I would circle back to the finances. So the allocation for the services in scope of delegation for our ICB will be approximately 236 million. All 11 ICBs in the Midlands have agreed to maintain that through a pooled fund in 24-25. Because there are a mix of retained and delegated services, we've agreed to a single contractual meeting with NHS England colleagues and relevant providers to ensure we've got the visibility across the piece, as I say. And the vast majority of services within scope of the contracts are operated on a block basis, and therefore there is no exposure to activity variance. We're also able to confirm that the elective activity through specialist commissioning will be eligible for the elective recovery fund, which is an important point of financial planning principles. And just to recognise that there are some activity lines, so renal, chemotherapy, neonatal, for example, that do operate on an activity basis with some cost per case elements. So there is a theoretical risk of overperformance, but we've established a 0.5% contingency fund to manage that risk in year. In terms of clinical and quality governance, there are a number of arrangements that are already set up which will be expanded on. So the ICB will continue to access clinical and quality functions through the Midlands team, and the Collaborative Clinical Executive Forum, of which our own ICB CMO is a member, Chief Medical Officer is a member, will continue to meet and feed advice into the decision-making process. There will then be a specialised commissioning quality group, which will continue to be chaired by the Regional Medical Director. That has representation from each ICB and does have the potential to escalate risks either through to the Midlands Acute Specialist Commissioning Group or the West Midlands Joint Committee, which I'll talk about in a moment. So then just to cover off the regional governance and how it interfaces then with our own ICB arrangements, the West Midlands Joint Committee, which is constituted of ICB CEOs and Regional Director of NHS England. That was established as part of the pod delegations, so that's been refreshed to include now the specialised services. And as I referenced on the previous slide, there are a number of subgroups that look at commissioning and planning, financial management and quality oversight, and the Collaborative Clinical Executive Group will continue to meet. Importantly, and I've made this point at various points in this presentation, all of those forums will look at both the retained and delegated functions so that we've got visibility across the totality of the specialised commissioning portfolio. The interface with the ICB is essentially on the principle that relevant topics will go to relevant committees. So finance and performance will be incorporated into Finance and Performance Committee, quality surveillance and quality monitoring into quality and safety, etc., etc. Perhaps important just to note that the design and operation of and compliance with the delegated function arrangements will be included in the scope of the ICB internal audit programme, and that will include compliance with the scope of the delegations, and again is consistent with the pods, and the ICB audit committee in 23-24 has considered an internal audit review of the arrangements with the pods, and the same will be true then of specialised services going forward. And again, just to note that NHS England are leading the development of a post-delegation assurance framework, so that essentially gives us a checkpoint where we're able to reflect the progress we've made and any risks and issues and how they've been mitigated in year, and we will of course make that available to ICB board at a point in 24-25 when it's available. Just a couple of more points to make just in terms of the due diligence. As I say, we've been working throughout 23-24 with ICB, NHS England colleagues. Sorry, so there's just a list there of all the different due diligence mechanisms that we've been going through, including the operating model group, of which I'm a member representing our ICB, and the chief exec timeout sessions, which obviously Peter has been to. And then I think as we turn the calendar over into 24, we realised there was a need perhaps just to amplify certain elements of the due diligence process. So there's been more granular work then into quality, finance, resources and the benefits, and I've spoke about each of those as we've gone through. As I mentioned earlier, the delegation agreement is the one document that's available in the public pack, and it is the document that the ICB board is invited to review and approve specifically. There are, though, then a number of supporting documentation, which again are detailed in the report, which describe the collaborative and interoperable nature of the relationship, both with NHS England and then across the 11 ICBs. And perhaps most importantly includes a service profile. So this is essentially a receiving document for us as an ICB, which gives us a much clearer understanding of the services in the ICB area and the nature of those that at the point of transition. And then finally, just being mindful of time, there are some areas that would benefit from further review in 24-25, and colleagues can see them there from governance through to finance and contracting. I won't go through them all. And then just perhaps important to note that again through 24-25 we will continue to work as ICBs with NHS England on the next wave of delegations, which are due to go live from April 2025. And we'll bring updates through Finance Performance Committee as we have with the preparation for the delegations that we're now considering. So I'll pause there, David, conscious that again there's a lot in there. I'll stop sharing my screen, but as I say, happy to take questions and comments.
Okay, Chris, thanks very much for that, for taking us through the presentation, because it's really helpful to bring all of that to life. And I just want to thank you as well for identifying the linkage with our own governance structure within the ICB. So I just wanted to check, given that this is going to go live in a couple of weeks or a week, are we planning to review the subcommittee structures, terms of reference, etc., to make sure that those docking arrangements with this new arrangement is clearly in place? And I know my colleague Julie Holder, Chair of Audit, will be keen to know that, you know, to oversee the audit arrangements that you described in there. And I see Julie's popped her hand up. But first on the terms of reference, Chris, and just being very clear, you know, how this comes back into the organisation, so it's not almost delegated to another consortia. You know, we're very much involved and managing any risks or opportunities and transformational developments through those mechanisms.
Yeah, absolutely. So I think I'd perhaps say two things, David. One is that obviously we're inviting the board to consider the proposals around the delegation today. So in the event that the board are supportive, there is then absolutely work for us to do with colleagues in corporate governance, just to make sure that the terms of reference of those committees are refreshed to reflect the fact that their scope is slightly broader than perhaps it is in 23-24. Although, as I say, the inclusion of finance reports into finance performance committee, quality reports into quality and safety would generally be in scope of those committees, but there might just be some finer points that we need to work through with Tracy and Paul and chairs of those committees. And I guess just to reference that in our board development session later on today, I think we are considering the outcomes of the governance review. And that might just give us some food for thought then in terms of the exact nature of how we reflect the interface arrangements into the refreshed governance arrangements in 24-25.
Thanks, Chris. I think that's really helpful, particularly the link back to the governance review. And just finally, before I hand over to Julie and Steve, just on 16.3 of the document, which is on page 46, it talks about the indemnity, I think it is, liability and indemnity. And it just talks about exceeding the authority. I get the others, which clearly, is very clear. Just in terms of, obviously this is a document we'll view today. Who keeps an eye on, the authority? We haven't exceeded the authority. The consortium doesn't exceed the authority, and those sort of risks.
Yeah, indeed. So hand in hand with these arrangements are some changes to the ICB scheme of delegation, which need to provide for decisions then that are made around the specialised commissioning decisions. As I say, given the nature of the NHS England commissioning team being retained by NHS England, the collaborative agreement then in particular describes how decisions made by the ICB will be transacted through NHS England staff where it's appropriate for that to happen. And then I think within the presentation I signalled that within the ICB's internal audit programme we would include a review of the specialised commissioning arrangements, which would include compliance with the scope of the delegated functions.
Thanks, Chris. That's a neat point to bring Julie in. Welcome, Julie.
Thanks very much, David. Thanks, Chris. That was very useful slides because it is very complex. I just want to make sure that we don't lose. So it's good. Can you hear me? I'm having problems with this.
Yeah, it's quite faint, Julie. So you might just need to.
Is that better?
That's much better. Thank you.
Okay, thanks very much. I just want to make sure that when we look at the terms of reference that we don't forget audit committee, not just around actually putting it into the internal audit plan. And the other thing I just wanted to be clear about is in terms of when we are allocated funding, is this over and above the normal allocations, separate to the allocations? And I just wanted to be clear about the scope then, I think you sort of touched upon it, for actually creating different ways of working, transformation for individual trusts and then for the system. So that is allowable. It's not something that the other governance arrangements would preclude.
Thanks, Julie.
Yeah, so all of that. So I think on the point of the audit committee, absolutely. I think we'd want to work with all the chairs of all the committees to make sure that we'd got that appropriately covered off. And then, yes, I think that as I say, it's perhaps it was implicit rather than explicit, but the whole point of the delegations really is to enable that visibility by ICBs across the totality of the pathways, with a view then that ICBs will bring forward transformation pathway redesign, which will seek to improve the way in which services are delivered. I think it goes hand in hand with that then, that there may be some contractual and financial changes that follow. So yes, absolutely, that's within the parameters of the delegations. I think NHS England within the delegated agreement do put some safeguards in about perhaps ICBs operating in isolation from the multi-collaborative nature. So I think we'd want to do that via the the Midlands Acute Specialised Commissioning Group, for example, and make sure that where we're proposing change for specialised services located in our ICB, that the neighbouring systems are supportive of that. But yes, it's permissible within the delegations.
Thanks, Chris. Thanks, Julie. Steve, welcome.
Hi, thank you, Chair. Thanks, Chris. Really, really useful. I think it's easy to say this, Chair, but there's a lot happening in this space. I mean, there's a national call this afternoon on this. You know, it moves quite quickly. And although principally, Chris, I think the paper describes some of the functions around the delegated act around commissioning, there is something here that would be helpful, Chair, because some of the SpecCom delivery is at a regionalised level. So some of the mental health and specialist mental health elements, such as forensics, eating disorders, perinatal, are at a population of maybe 5-10 million, i.e. 3-4-5 ICB areas. So Chris, maybe offline when you're doing the alignment piece inside the ICB, it would be quite helpful just to touch base to make sure that that's in the context of the other regionalised pieces of work.
Okay, helpful there, Steve and Chris. I'm taking we can note Steve's question and take account of it.
And it's very, very pertinent, actually, particularly for the next wave of delegations that we'll be co-producing with NHS England colleagues in 24-25, because they do bring into scope some of those more specialist mental health, learning disability services that are operated through those regional clubs that Steve references.
Thank you.
Okay, thanks, Steve. Paul Brown, welcome.
Thanks, David. Yes, just want to make the point, this is extra allocation into the ICB, as Chris has said, out of 235 million. A lot of that expenditure is really sitting within the books of providers within MPFT and within UH&M. I think as Chris has articulated, there's a lot of sense in looking across the whole pathway, so having that money in one place makes sense. The comment I wanted to make, David, just to link this in terms of the item upcoming on the plan for next year and the financial risks that this may bring, effectively assuming zero risk, zero opportunity, that it will be neutral. I think there's a reasonably good chance that that is going to be the case this year. It's effectively a trial, the delegation. I mean, I would say we're not as well sighted on those risks and opportunities as we would ideally want to be, but I think we can take assurance from the fact that nationally, because we've agreed, we were suggesting, if approved here, that the West Midlands will be one of the pilot regions. I think it's a reasonably solid assumption that we can take, that if there is any unexpected risk, that we will be shielded from that. That's not a complete guarantee, but that's our what we've been told. So I think we can take some assurance from that. So from my perspective, David, financially, it makes sense to do this now. It gives us a year to really get under the bonnet of all these issues. As I say, work closely with our providers where the majority of the spend sits. But I just wanted to make the point that in terms of our plan, we've assumed zero risk, zero opportunity from this.
Paul, thank you. That's really helpful. Megan.
Thank you. Thanks, Chris. I just wanted to pick up the benefits as they're set out, and it was very helpful. I attended a Midlands seminar for NEDs on this last week or the week before, I can't remember, which was very helpful and really did emphasise the future benefits around the whole pathway approach, which we can adopt going forwards. But I also think it's important to note that there are going to be some difficult decisions ahead as well. There was one quality service profile included, I think, in the wider pack that have come out, that came out to board members, and that picked up in particular specialised vascular services, which was the profile, and the fact that there were 12 centres in the Midlands, but only one in the West Midlands, which currently is compliant on staffing activity levels. And the view within the pack that I felt that the region could only really support 9 or 10 going forward. There are difficult decisions ahead around this, and although there are, it is great that we can look at things like equity of access for all patients. There are some difficult decisions ahead as well, where actually we have too many centres and some across the region. So I just think it's worth noting that as well. Thank you.
Thanks very much, Megan, for the question. Chris, noted.
Yeah, absolutely, and absolutely fair comment. The nature of specialised provision to an extent means does need to be a balance between access and specialisms, at risk of perhaps stating the obvious, and that comes with you know, a degree of activity and throughput for some clinicians to maintain that level of specialism and their clinical competence. So that does beg those questions from time to time. Equally, the reverse is true, that on occasion we have services that that perhaps present with a degree of risk because we've not got sufficiency of clinician around those services. So we will absolutely need to remain vigilant in the way that Megan suggests, and I'm sure there will be points where we need to make some or contribute to some really difficult decisions. But I think I go back to Paul's point in essence, which is better to have that delegated responsibility now and work through that in 24-25, pending the full geographical delegations of other systems in 25-26.
Yeah, thanks, Chris. I think that's a point well made. Finally, Tracy.
Yeah, just really looking at this from a member of public or patient perspective who don't see who buys their services, do they? They just see their services being received. So for me, I see this as a positive in us to be able to actually look at the services that we commission, so to speak, and be able to involve our public with that. So looking across the pathway, to me, it looks quite important that we do actually have this opportunity that we can seek more from what our public see in terms of they move through different services, don't they? Move into specialised commissioning, them perhaps move back to things that we commission. So the more we can see about that pathway for them, I think the better it is for our public.
Yeah, great point, Tracy, and thank you for raising that. Okay, so Chris, just coming to the recommendations then that we've got in front of us, what I'd like to do is to frame them against the points that have been raised by the board members this afternoon, and particularly that piece around the ongoing governance review and that docking and linkage and oversight. You know, Paul was talking about that as well. So, you know, this isn't something that, I'm sure it won't, happens over here while we're dealing with the other business. It needs to be fully integrated with our approach. So on that basis, we're being asked to approve the delegation of the defined set of 59 specialist acute services to the ICB from the 1st of April 2024, and to delegate the final signature of the National Delegation Agreement to the Chair and Chief Executive of the ICB in the context of the collective ICB position across the Midlands region. So are the board happy to approve that? Thank you. Chris, thanks very much. Hell of a lot of work in that process and more to come. So thank you for everything, and thank you to the board for supporting that. So Chris, we'll keep you on screen if we can. We'll move straight into item 9, the joint forward plan, and can I hand back to you?
Yeah, thank you, David. So there's no presentation to support the JFP update, so the papers are in the pack. I perhaps just want to start with a thank you to the planning team. Actually, in Paul Brown's area, they've worked tirelessly over the past few weeks, in particular, but months actually, to get us to this point. I am indebted to that team. So the JFP, just by way of a reminder, it's a 5-year plan. Which describes in some detail how the ICB and its partners will deliver the long-term strategic ambitions that are articulated in the ICP strategy. ICBs are required to refresh the JFP annually, but we also recognise that our first inaugural joint forward plan was only published in June 2023, so only kind of 9 months ago. So with that in mind, we've previously agreed approach with the board that essentially this refresh would be a companion piece to be read in conjunction with our inaugural JFP, and that we'd focus on 3 things. We would reflect national guidance that's been updated in the past 9 months or so, and I'd draw attention to primary care access recovery plan, the delegations that we've just considered, as well as the pharmacy, ophthalmology and dentistry ones from last year, and then new commitments around maternity and neonates that were reflected in the refresh. We agreed to refresh our strategic direction where there'd been some further thought about that. So you can see within the document, we talk about our continued focus on inequalities with much more detail around that than perhaps our first version, and that leads into an iteration then around our operating model and particularly our approach to communities and how we're developing a health offer which augments the work that other agencies are already doing to connect to our communities and neighbourhoods. And then we agreed that we would report on progress of the programmes that we set out in the first JFP. So there are points of reflection around inpatient mental services, all the work we've done to kind of develop a strategy framework to create a platform for further redesign, and then the work we've done around research and innovation. As with the original JFP, the refresh needs to include supporting statements from our health and wellbeing boards. So the design and approach that I've just gone through was also supported by both Stoke and Staffordshire Health and Wellbeing boards, and we've worked closely with the local authority directors of public health and their teams to ensure the content is reflective of health and wellbeing board direction of travel. And the draft that colleagues have got before you today is also currently out to Staffordshire Health and Wellbeing Board and is due to be presented to the Stoke Health and Wellbeing Board later this month. And as a piece of assurance, we've also had a review conducted through NHS England, which was generally really positive. There were some bits that they just wanted to update on, and that's reflected in the document that you've got available today. So this isn't the final version, because the timing of the health and wellbeing boards mean that we just need to orchestrate that finalisation over the next couple of weeks, and therefore the ask of the board for now is comments on this version, and we can do that even now through questioning or by contributions over email to me over the next couple of days perhaps, and then to delegate signature to yourself, Chair, and the Chief Executive, just to allow that final iteration from comments from today and the health and wellbeing boards, so that we've got a consolidated document by the end of the month.
Thanks, Chris. A lot of work gone into that, and from my reading of it, seems to be shaping up very well. Just take any questions or comments on this item, Peter.
Yeah, thank you, David. So firstly, a thank you to everybody that's contributed. Chris has essentially overseen this, but there's been a lot of people behind the scenes that have dedicated themselves to get the document into this place. It's a hugely important piece because it essentially spans the distance, or the potential distance, between our ICP strategy and our in-year delivery document. So to help describe how we create that conversion from strategy narrative through to in the moment delivery is really important, isn't it? The bit for me that I hope comes out loud and clear, but fundamentally needs to, and it links to one of my comments from our paper, David, earlier on, is the piece around community transformation. So I think we can articulate quite well in the system how we deliver on our urgent and emergency care programme, and of course we have a UEC portfolio. I think we now articulate quite well and do very well, of course, within the mental health and LDA arena. I think the community transformation element is the big opportunity in 24, 25 and beyond, particularly, of course, to address inequalities, but to fundamentally ground ourselves in local communities through integrated multidisciplinary teams, high quality data, the right interventions at localized level. And we've got a job of work to do to get where we want to be on that. So I hope that opportunity comes through loud and clear within the JFP. But for me, that's, I suppose, just firstly to say a big thank you, and secondly, that is for me the big opportunity over the next couple of years.
Thanks, Peter. So just taking a couple more quick observations and then move to the recommendations. Steve, first.
Thank you, Chair, and again, actually echo Peter's words there, because I think JFP's, whatever we call these things, joint forward plans, capture both the vision and the commitment to our populations over the next couple of years. They're really important. It's a bit of an offer, Chair, from a day job perspective as a director of strategy, and I think, Chris, what would be really useful, given the fact that we are trying to battle with recovery plans, operational plans and guidance plans, whether or not, Chair, it would be useful to just do a second crank through as a read across with all of the provider plans, just to make sure they all dovetail. So all of our partners, our local authorities and providers can then own and link in with the JFP for the system, so it becomes a system document rather than individual bits of documents, if that makes sense. So, Chris, a bit of an offer there in terms of a strategic read across.
Okay, thanks for that, Steve. And pick that up with Chris. I'm sure that would be very helpful. Julie.
So it's just picking up, I totally agree with what Peter said, and also Steve, that read across would be good. I suppose it's just a bit of a reality check, given the challenging nature of the finances in the next 12 months. It is a big opportunity, and totally agree. It's the impact of that that's going to have on the joint forward plan. How are we accommodating that challenge as we go forward? Is it realistic, I guess, is what I'm saying, that we're about to actually publish?
Yeah, thanks, Julie. I'm going to bring Megan in because she's got a hand up, and I presume Megan might be responding to that point.
It was actually to echo that point, really. So as I read, I mean, I think it's a really well written document. I think it's a really positive document. But the one bit for me really was there's a section there about our finances, and it was just the reality of our finances and how that impacts upon the rest of our ambitions, really, and whether that is fully fleshed out, I suppose. Thank you.
Okay, so just on that point, just looking at Paul, I guess, and Chris, and Steve's point about the read across, is that's something we've still got time to be able to reflect that more strongly, Chris, in the plan from what you said?
Yes, absolutely. So we are required to publish by the end of March. So there is time, although it's limited. Bearing in mind we've got Easter coming up, I guess. But we'll pick colleagues up on their offers, and perhaps Paul and I will give some thought to how we articulate the balance, I think, between the imperative around recovery, but equally the need for us to be able to deliver the transformation that's articulated in the JFP, because at risk, I guess, of stating the obvious, going back to Peter's kind of split screen analogy earlier, we need to be able to do both. The recovery is absolutely in the here and now, and it's imperative in 24-25, but equally we need to be bringing forward proposals and programs of change which positively influence kind of future patterns of demand. And that's the balance that I think we're seeking to strive. So I think Julie noted, and perhaps Paul and I will give some thought to how we articulate that perhaps a bit more clearly within the document.
Okay, thanks very much, Julie. Megan, thank you for those points. Tracy?
Just Chair, on a formality, there's a member of the public who put something in the chat. We'll address them at the end, and I'll keep an eye on them for the end of the meeting. I just don't want them to think that they're being ignored.
Thank you, Tracy. Yes, we'll pick everything up. So the author of that comment will get a response at the end. Okay, so Chris, I think just in terms of the recommendations here, it does say approve this final draft. We're not necessarily doing that today, are we? We're noting almost the development of the plan to this point, given further work within that pretty collapsed timescale that you've just described. So we're waiting for the health and wellbeing boards, and the important points there that were just made by colleagues around the financial realities, just making sure that they're clearly articulated. So what I'd like to suggest is that we're noting the most current draft of the joint forward plan, with the caveat that the fully designated design document rather will be developed for the 6th of April publication date, as it says here, and then agree delegated approval to the chair and chief executive for sign off, allowing any final feedback from the health and wellbeing boards or further work and refinement that we've taken forward from today.
Indeed.
Okay,
thank you.
So happy with that. Thank you, Chris. Thank you for that. We're going to move straight on because we are slightly behind time, but these are very important discussions that we're engaged in this afternoon. So welcome, Chris. We'll move into item 10 if we can. the data and intelligence strategy implementation. Over to you.
Great, thank you very much, David, and thank you very much for the opportunity to present this important strategy. I do want to, right up front, and I know Colin Finn is on the call, I do want to acknowledge the excellent work that Colin has done over the past number of months, not only from a top-down point of view, but working very actively with our ICS partners in putting this strategy together. So while this refers to an ICB board intelligence strategy, it reflects the needs of the broader ICS itself. And I think it should go without saying that I fully endorse what's in this strategy that I'm about to present. I only have a couple of slides just to set the expectation, but I'm going to start, if you don't mind, just with looking at setting this within the context of our digital roadmap. Now, this will be very familiar to many people, but the intelligence strategy is not in splendid isolation. It actually reflects a number of these different activities that we're currently undertaking as an ICS. So it plays, and I'll talk to it in a moment, but it picks up on points around digital learning, around skills development of our workforce. It majors on the middle part, the shared care record, on the data access and business intelligence, data warehousing, population health management, but also it lays the groundwork for us to move forward with rather exciting technologies around machine learning, artificial intelligence, and so forth. So very briefly, I'm just going to pick up, this is the key slide that I'm going to talk to. These are the 5 strategic goals which underpin the strategy. I will take the report as read because there's more detail in the report, but it's fair to say that the strategy is relatively high level. There's a piece of work that we need to move on to, which is really fleshing this out and defining a transformation roadmap against which these goals can then be realized. And I just wanted to talk very briefly to some of these. The first one is top left. We really need to focus on developing a data-centric culture and workforce, both from a skills point of view, but also using information most effectively to make decisions around the care that we provide to our patients. The second area that the strategy focuses on is having conceptually a unified information asset and information repository to provide that single version of the truth, that we can actually provide consistent reporting, but also provide information right across, all the way from social care through our acute provision, providing that information that we can make effective, preventative, proactive decisions. The third area that it picks up on is around the governance processes, predominantly around information governance. We have been challenged by this over the past year, and I feel we are making good progress in this area, but we need to really free up information access, make it available to our clinicians, to our operational staff, so that we can actually drive improvements, we can identify cohorts of individuals and target interventions. The fourth area is really around intuitive reporting and insight. We need to have analytics that is readily available to our clinical staff predominantly, but it's also to our operational staff, as I say, and it's really to focus on things like improving productivity. It's about identification and reduction of inequalities of service provision. It's about targeting and prioritizing patient care in the right way. It's understanding bottlenecks in our service provision, both in demand and supply. And it, as I said before, it sets the groundwork for introduction of much more advanced technologies around artificial intelligence, where we can really improve the speed, the turnaround and quality, including things like diagnostics. And finally, this plays to the sort of back office consolidation. It's about making a sort of ICS-wide intelligence function, because currently we operate very much in isolation, in silos across various providers. and we need to work on how we can work more effectively together to drive efficiencies of scale. So that's what's inside the intelligence strategy itself. Just to close, the board is being asked to endorse and approve this intelligence strategy, but the next steps, as I mentioned before, we want to prioritize a program manager to take this forward over the next 6 months to flesh out the milestones, the deliverables, those dependencies, those timelines against which we can track progress to realize those 5 different goals that I just talked to. I'm not asking for any additional budget. This is already included within the digital team budget, but it's to make sure that we have a particular focus on producing this transformation plan at the end of Q2, which we will then bring back to the board and share how we're going to execute that strategy moving forward. So I'll stop at that point and ask if there are any questions.
Thanks very much, Chris. Very important document. And again, thank you very much for all the hard work that's gone into that. Got a few questions we'll pick up. First off, Megan.
Thank you. Thanks, Chris. I think it's a really important document that you've brought here today, and I strongly support it. My question is really around the pace, I suppose, given that so much of what we want to deliver, particularly on health inequalities, is dependent on having good data sharing. The conclusion talks about the fact that we're not having a big bang approach. It's a pragmatic, incremental approach. Are we moving fast enough to deliver on the ambitions that we've got?
That's a really good question. Thanks for raising it, Megan. My subjective view on that is no. I think we can move at significantly greater pace because the infrastructure that's required, the information and informatics infrastructure, is already in situ. So I think we have certain barriers. I referred to them. I say barriers, I need to be sensitive with my wording, but we need to actually free up our information assets, and we are working very closely with our information governance colleagues to attempt to do that. And I'm optimistic that we can actually make good headway more rapidly than one might expect.
Thanks very much, Chris. Great question, Megan. Thank you. Showkat, welcome.
Thank you. Thank you, David. Chris, thanks for the presentation. Really good presentation. And I'm really glad that you had the slide in there that was around the intelligence strategy, because I think that's really key. When we talk about artificial intelligence and the power of AI, I think it gets a bad press at times because the assumption is it's about robotics and that you lose the ability to talk to a human being and it's all the things which kind of worries a lot of people. But this is about really driving through significant change, and it links a little bit to the point that Megan was making, because really good data intelligence should inform resources and priorities and how and what our approach should be, particularly with scarce resources. And my bit of the question really is that I know you've been quite clear that you're not coming here asking for more resources, but my worry in all of this is that it's the people at the other end, in terms of once that data is there, how that data is produced, and having the data in a way which can make it easily interpreted. So if it's not easily interpreted and people can't analyze it, you need people on an analysis side who are providing that information in a very plain English way, where that, well, okay, based on that, our forward plan and our vision is actually tailored and our resources are then prioritized appropriately. And my only worry or concern in this is, from an information governance point of view, are the resources right in there to be able to carry forward with this? So you'll have the data, but actually you need the resources at the other end to make sure it's interpreted in the right way. Thank you.
No, I mean, it's an excellent question. And I think there's a major business change undertaking that's required here. Some people refer to it as cultural change, but certainly business change in terms of, at the moment, we have a lot of data, but it's not quite so easy for people to make use of that information in a fairly straightforward fashion. So we need to make, this is a journey. It's one of the points I picked up in the goals. We need to be able to, we need to get to a point where we're embedding the use of analytics within our day-to-day processes, and rather than using it as an adjunct at some later point. So as and when you're engaging with patients in their care, that we're actually using information and making decisions based on that evidence, and done in a simple way. Now that sounds a lot easier than it is. So I think this is a multi-year journey. I think I put that in the strategy, but yeah, so thank you for the question.
Yeah, thanks very much, Showkat, for that. Take two more questions, Peter and then Paddy.
Yes, firstly, again, I'll thank Chris and everybody else behind the scenes for pulling this together. I know it's a system-wide effort, and that in itself is, you know, a real achievement. So a big thank you. I'm gonna push Chris and colleagues a little bit. So there's a description of a virtual, an ambition around a virtual ICS-wide intelligence function. Why virtual? Why couldn't we pull all of our intelligence, people and skills and capacity together to create an actual system-wide intelligence function? Maybe not one to debate now, but are we actually going far enough in terms of that combined opportunity around BI that then has to drive, you know, our decision making across the system? And we've got a lot of decisions to make over coming years. So are we going far enough?
Peter, it's a very good challenge. I think it's something we're going to have to discuss, and it will require the buy-in of individual sovereign organizations to get to that point. Hence the reason why we said virtual, because that's something that's eminently doable. But I think it's something we need to discuss in more detail.
Yeah. Thanks, Peter, for the challenge, and thanks, Chris. Paddy.
Chris, welcome the strategy and seeing it at board today. Feels like a really important piece of work. I also welcome the recognition that I think you described it as that sort of culture around the use of data is recognised within that, and it seems to be it's probably quite a challenge. I think the way we've used data in the past isn't where we're going to see ourselves developing in the next few years, and certainly when you start talking about machine learning and AI and how we use that data. So it feels like there's quite a lot of work to do with our clinicians and with our sort of programs of work, particularly the sort of clinical programs, as to how we change that culture of the use of data and how we sort of move forward with that. And I guess there's a risk about that sort of disconnect between a sort of technical digital piece of work and then the sort of clinical and the frontline work. So I guess just a question really around how we bring those two together and we don't sort of go on parallel tracks.
I referred to it a little bit earlier, Paddy, when I talked about business change and cultural change, and you're absolutely spot on. You can't drive this type of stuff solely from a digital and technology perspective. It has to be done hand in glove with our clinicians. So I think there's a significant business change element that we're going to have to work through in coming years. But all I can say is this, for me, artificial intelligence is akin to the Industrial Revolution. I think it's going to be dramatic over the next number of years, but it's evolving. So, for example, there are significant, well, NHS England is engaging significantly with major technology suppliers. One of them is Google, for example, starting to explore practically how this new technology can be used. And there's a huge information governance element to this as well, which is somewhat unknown at this point, which we'll need to work through as well, but very exciting.
Okay, thanks, Paddy. Thanks, Chris. We're out of time, but I'll bring you in quickly if it's a quick point you want to make.
It is very quick, Chair. Just to say, a couple of colleagues have referenced this already, but later on the agenda we've got an update on the financial planning for 24-25, and that includes a number of system collaboratives, including corporate and back office. And I think, Chris, there's probably a conversation to be had referencing Peter's challenge about not just in this area, in fairness, but that our level of ambition in our assumptions about virtual versus tangible consolidation effectively. So I'll just make that point for now, but just to echo the need perhaps for us to be a little bit more ambitious in some of our assumptions.
Okay,
Thanks very much, Chris. So, Chris, thanks very much for a very stimulating presentation. Obviously, got some great questions for clarification and some ideas for the future. We are approving the implementation of the ICS data and intelligence strategy today. And as you said at the start, look forward to those regular updates around that implementation process over forthcoming months. So thanks very much, Chris, assuming everybody on the board is happy to endorse that recommendation. Thanks very much, Chris. If we can move straight into item 11, we've got enclosure 9, and Heather, what I suggest is when you've presented what the escalations out of enclosure 9, if Josie joins just to give the chair's update as well, that would be really helpful.
Okay, thank you, Chair, and I'll keep this as brief as I can in the interest of being tight for time. I normally take this report as read anyway, but there were, as always, a couple of things that I just wanted to pick out specifically and draw everybody's attention to and or add to since the meetings took place. So the first one is some positive news in terms of the application of and progress in relation to continuing healthcare. I think most people are aware that we have established a collaborative which is working, still very early days, but working very, very well. And we've seen a number of notable improvements in the continuing healthcare arena over the last few months. And I mention that not only because it is a financial benefit, because of course any improvements you make there will always bring financial benefit, but more importantly, it's about the patient experience and the patient journey. So significant improvements being noted already in patients who are using those services. So really, really important that we flag that alongside any cost benefits that might be occurring anyway. In terms of the risk register, you'll note from the report that we, as always, reviewed the risk register in detail and the relevant risks were discussed. I've drawn out actually the fact that we also added on an additional risk in relation to surgical termination of pregnancy services, and that was on the back of an unexpected closure of a service, which just happens to be quite some distance from Staffordshire and Stoke-on-Trent. That's highlighted a potential risk around lack of provision locally. And as you might imagine, we are undertaking a more detailed quality impact assessment to make sure that our service users of those services are able to access services locally if they can. From a maternity LMNS, local maternity and neonatal service, I shouldn't use abbreviations, apologies, point of view. I know previously we reported some challenges, but I just wanted to highlight that last Friday we did a joint visit, quite a lot of us actually, with the regional chief nursing officer, the regional acting chief midwifery officer, and had a very positive visit up to maternity and neonatal at UHNM. Marked improvement in a number of key areas that had been flagged not only in our previous work but also by the CQC as part of their review. And I know that there is a communication en route to UHNM from region imminently. So I just wanted to share that. And I know we talked about the maternity work in the paper. And then finally, and again, for anybody who's not picked it up elsewhere, which I think most people would have done, just to remind everybody that West Midlands Ambulance Service have had their CQC report now, and their rating is now good. That is a slight reduction. And of course, as always, we are linking with the lead integrated care board regarding required improvement actions to hopefully get them back to outstanding where they were. Other than that, there was nothing else I wanted to pick up, and I'm happy to take any questions.
Thanks very much, Heather. We'll just pause and take any questions if there's anything specific for Heather on the items covered. If not, Josie, could I ask you if you'd just give any escalations you want to give from your report?
Thank you, David. And actually, Heather's touched on the two items I was going to mention, one around the surgical termination of pregnancy, which Heather's explained, and the other about the we're really delighted to see the improvements now around the maternity services. I know there's a lot more work to do, but given where we were not that long ago, things are starting to move in the right direction. So we're really pleased to see that. Thank you.
Thanks very much, Josie, and echo that. So just check if there's any questions on either Josie's report or Heather's? If not, we will receive the report for clarification and further action as appropriate. Be assured in relation to the key quality assurance and patient safety activity undertaken in respect of matters relevant to all parts of the integrated care system, and ratify the decisions of the Quality and Safety Committee with regards to the quality impact assessment policy. And in terms of Josie's escalation report, take assurance regarding the reports provided in the discussion that took place at the committee. Thank you both for all the work you're doing with that very important committee. So Paul, if we could, and Phil, if we could move into item 12, finance and performance. Over to you.
Thank you. The report has been scrutinised already, of course, at System Performance Group and System F&P Finance and Performance Committee that Megan will talk to in a second. Just wanted to quickly reference the summary on slide 191 of the pack, which I think just gives a snapshot of performance across the piece. It does reference actually where Heather and Josie were in terms of some good performance in terms of maternity. I think we should just note some good performance, particularly in primary care this year, some good improvements there. And one that we're very, very proud of is the improvements we made in end of life, where we've made some big improvements in terms of the number of people who die in their choice of place. So we should note the good performance on that, if that's okay. In terms of the finance, I'll touch on that then, as ever, just hand over to Phil to talk about the other areas of performance. But the finance story is quite straightforward. It's been the same picture now for a few months. You will recall we're given the approval to a deficit of up to 91.4 million. So we've been looking to make sure we achieve that the last few months. We're still on track to do that. That's a system number. All of that deficit sits with the ICB, but we work closely across the system to manage the costs, and we are still on track to deliver that. And that was, again, if you recall back to the late summer, early autumn, we were headed for 141 million, and the recovery plan has kicked in and delivered, so far has delivered that improvement that we sought. So whilst obviously deficit is not where we wanted to end the year, we have seen an improvement in the run rate in the second half of the year, and I'll come back and talk a bit about that in terms of the plan, David, in a second, but I'll stop there and then either hand to Phil now or take questions on the finance, whichever you prefer.
We'll take them both in the round if we can, Paul, in a moment. Thank you for that. Phil.
Thank you, Chair, and thanks, Paul. I'll just pick up a few highlights and then obviously any questions that there are. So urgent emergency care remains a challenging context that we are working in, but really positive that we have seen some noticeable improvement overall in the last month, and some of this supersedes the papers that have been issued today. Certainly for the latest reporting week, we've seen that our category 2 ambulance response time has improved to 30 minutes, which is within the national target and actually places us as second best out of 11 systems within the Midlands region. So I think that's really, really positive. The board is aware that we'd received a national ask to deliver significant improvement in 4-hour performance in our emergency departments during March. Previously, we were running around the 63% mark. We've seen improvement to just over 69% as of today. For month to date, we're not at the 75% that the region wanted, but we have seen an improving trajectory there, and there's a system plan in support of that. The other observation I'd just make is that where we have seen periods of escalation, as we have done this week, where we've had significant IPC pressures, the system has worked well together, and the bounce back from those times has been far quicker than I've previously seen. Other few bits just to flag are that we've made the decision to maintain all surge capacity to beyond the Easter period. So that essentially takes us up to the end of April, which is prudent given the pressures that we often see during April. But we are developing a de-escalation plan and indeed capacity plan for the year ahead that matches the demand curve that we expect. During April, we will also have a system learning event reflecting on winter, as we have done previously, and obviously presenting those findings back through to FPC committee. Two other brief bits I just wanted to flag around urgent care. Firstly, Some good news, we've been subject to a national UEC board assurance process in terms of how our system coordination centre, our SCC, operates, essentially how we manage our system. And we've just been notified that we've been awarded 100% compliance, and they've even sent us a certificate to prove it. So we've got something really positive there. The second bit is just in terms of the ambulance service. Heather mentioned around the recent CQC report. We've been in discussions with the lead commissioner around a number of things, but the key bit I want to bring to the board's attention is that there's going to be an independent review carried out in terms of demand and capacity for the ambulance service across the whole WMS footprint. We're obviously really keen to feed into that specification and be part of that review, because I think those findings will support us in terms of how we move forward as a system. Last couple of points just around planned care. The recovery of 78 weeks has obviously been challenging because we had further industrial action during Feb. We're now looking to be able to eliminate 78-week waits by the end of April. And then obviously we're working through in terms of next year eliminating 65-week waits as well. Some really positive news around cancer against the context of significant industrial action and obviously the urgent care pressures. We are now within our tolerance for backlog clearance for cancer patients for the year, which is a real improvement. We've seen it reduced from over 500 last summer to around 240 now. We have achieved that through significant additional non-recurrent resource that's been put in place. Cancer Alliance have been really supportive there, but I think absolute credit to UH&M and the way their teams have worked in terms of addressing those backlogs really robustly over a very challenging period. Thank you.
Yeah, good summary at the end there, Phil. I think, it's obvious the work and the traction that's been going on, particularly during this time of year. It really just demonstrates how much hard work is being put in place by teams. Megan, just for completeness, if you want to take any escalations from enclosure 12, your chair's report from F&P, we'll do that, and then we'll take any questions.
Thank you. Just three things. We've had a good conversation around the system recovery programme, which Paul's coming on to next on the agenda, and want to particularly flag up the importance of ensuring that sufficient capacity is aligned with the recovery programme going forward, in learning lessons from the current year. Second thing I wanted to raise was just in relation to the system financement 10 report, just to flag up that the position includes risks around the fixed and variable aspects of ERF, but does not include any provision for Band 2-3 retrospective payments, which are currently unquantified, and could have a significant impact. And then finally, some positive news I want to highlight around the medicines optimisation work, and that the 23-24 work is forecast to deliver between 4.2 million and 6 million cost savings in prescribing. Against an investment of 1.1 million, and we agreed a business case for 24-25, which plans to deliver 8.8 million with a maximum investment of 3.4 million. Thank you.
Megan, thanks very much. And I just minded reading the papers. It works really well, this process of actually aligning the chair's escalation report with the main reports for all of the committees, going back to quality and safety, and obviously later on for the other reports that come. So thank you very much for that. Really brings it to life. Just pause in terms of points of clarification. Any questions anybody wants to make? Okay, everybody seems content to receive the report. So we'll note the headlines, escalation and exceptions that have been brought to our attention. Note the year-to-date deficit position and efficiency delivery. And from Finance and Performance Committee Assurance Report, take assurance regarding the reports provided and the discussion that took place at that committee. Okay, thank you. So Paul, if we could move straight into item 13. Planning update, if I can hand back to you.
Yes, thank you. So if I can do this in two parts, if that's okay, David, just update you on the submission so far. So the three parts to that submission: the finance, component, workforce, which I asked Mish to talk to, and then the performance targets, which bring Phil back for, and then move on to talk a little bit about where we're developing our recovery plan, as Megan mentioned. So I'll start with the finance part. So as you've seen in the paper, the submission that we made at the end of February was for a system deficit of 179 million. That actually entails quite a significant level of improvement in some of the run rate costs, particularly around CHC. Unfortunately, that is masked by very significant use of money from the balance sheet, which we've now used and could only use once, which has meant that our in-year deficit, as we mentioned, of 91, actually it was a lot worse as an underlying number. We managed to bring it down to 91 through those one-off measures, which we have now utilised. So the position that we were in when we submitted the plan of 179 million was, I'm afraid, kind of where we expected to be, in the sense of we realised that we had those significant underlying challenges to deal with, and that's why we've done the work already now in terms of the recovery, which, as I say, I'll come on to in a second. At the point of the flash submission at the end of February, again from the report you'll have seen, we agreed a system CIP efficiency target of 3.44%. That we're very keen to make sure that we worked together, so that's all participants within the system using the same method. That was delivering quite significant savings, but not enough, obviously, to get us back into break even. We've since had a number of events with NHS colleagues, NHSE colleagues. The clear steer from the centre is that this is not an acceptable plan. The NHS does not have the funding to allow us to spend at this level, so we've given very clear instruction to increase the level of savings that we make, and we have done some work on that in the last few weeks. We also had useful conversation, David, with colleague chairs and of trust boards and chairs of finance committee, with chief executives and CFOs. That was helpful, I think, in terms of making sure we're all on the same page. And then just yesterday, we had an executive challenge session from the NHS England, which was challenging, as you'd expect. And again, we were asked to do better. But the positive part of the feedback was that it was evident to the team that we were joined up, all organisations working together, and grateful to colleagues from UHM and MPFT in particular, who joined us and spent a whole day in Birmingham. But I think we were able to give a very clear view to the team that we are joined up and we are working on this together. So there's plenty of positives in terms of that, but unfortunately, in terms of the bottom line financial number, it is not positive, and we have a lot of further work to do. That's where the recovery programme, I say, kicks in. I'll come back to that in a second, if that's okay, David, and perhaps just ask Mish now to say a few words about the workforce position.
Yeah, thanks, Paul. Mish?
Thank you. Thanks, Paul. So very similar to finance in the sense that the position is being come to very much in collaboration. Each of our organisations are absolutely clear that patient safety and service delivery is absolutely paramount, and we're all aligned in that. What we need to do is to continue to find the productivity savings, to make sure that we reduce duplication where we can, and to be more effective and efficient together. So we will put in a submission today. However, that's, it's a draft, and our final submission will go into May. So we'll continue to work collaboratively over the next few weeks, really, to consider how we can do things differently over organisational boundaries, where we can safely reduce workforce, where we feel that that's appropriate. As you can imagine, region and national colleagues are putting quite a lot of pressure on all systems in terms of workforce being the area that perhaps we need to consider to get us into a better financial position. We in Staffordshire are not over-established, and we're quite, there's not many of us like that. We've managed to get to our safe staffing levels, and we're working quite effectively in terms of additional activity and income generation from acquisition of business elsewhere. So we are quite complex from a workforce position, but I think it's fair to say that we're very transparent with each other, and we are learning from each other where we can, to make sure that we have all the grip and control in place that we can to get us into a better position.
Thanks, Mish.
Submission. Could we perhaps just go to Phil now, just to round it off with the performance targets that we've submitted?
Yeah, thank you. Thanks, Paul. Yeah, so certainly the information that's within the pack in front of you on page 210, setting out the flash submission key messages. We've moved on significantly since then from an operational perspective, as indeed Paul's outlined from a financial perspective. So essentially, in terms of what will be submitted today, we will be showing our intention to meet the improved emergency department 4-hour standard, also to meet the cancer 62-day standard. And as I say, we've done significant work in terms of clearing backlogs there, so that better places us to meet that performance standard. Now, in terms of activity and long waits, we've done significant work here, and the submission that will go in today will indicate that by September 24 that we can clear all of our 65-week waits, and there's an activity plan which is improved compared to what's in the pack there to meet that, which includes taking advantage of productivity opportunities, which we've been supported by national teams in order to identify, and also continuation of some one-off, i.e. beyond core activity initiative work to make sure we're keeping our activity levels high. The only risk I would flag in there is that we met with the national team yesterday and presented the plan, and then as I was travelling home I saw notification of the ballot to continue industrial action for the next 6-month period, which will obviously have an impact there as and when and if it plays in. But certainly at this point in time, I think we're submitting a good plan operationally that is well triangulated across the system and with finance and workforce. Thanks.
Thanks very much, Phil.
Thanks. If I could round off, David, then with what we're doing next. So as I said earlier, we knew that we face some fairly significant financial challenges and clinical challenges too. So we have been developing the shape of the recovery plan, and we discussed it here in this board before, but that's now taking really good shape. And just wanted to give a mention to Steve Grange, who's on the call, as he's here today, of course, as Deputy CEO, but is also Director of Strategy, and working with Helen Ashley from UHM and Liz Miller from Combined, along with our Chris Bird. This plan has been developed, and I think is looking really good, and it does build on, I think Peter touched on this, it builds on the learning from the current year. So things have worked, and what worked really well was the CHC collaborative, and it worked well because it was a collaborative. It worked across the system, and it recognised the whole pathway. And so we decided we wanted to build on that method, and the provider collaborative that Tracy Bullock leads is the vehicle through which we can now bring people together to deliver that whole pathway improvement. That the model that's in your pack on page 213 sets out how we've aimed to do that. So applying the priorities that we've already agreed to the circle, which you hopefully recognise, we then ask a series of questions about the things that we're doing. Do they address health inequalities? Do they improve clinical outcomes? And then they need to do one of the next 3 things, at least one of the next 3 things. They need to either reduce the level of activity in the secondary care sector, where we know we cannot afford or recruit to continually increase the size of the secondary care sector. Do they do that, or do they improve productivity? So as Mish mentioned, we know we've had some workforce improvements. So can we deliver more patient care through the workforce that we have? And then thirdly, do they take money out? Do they reduce costs? And probably most of the things that we do will not do all 3 of those at the same time. There'll be one of those things, but we need to blend those things as a package to deliver the improvements that we need to both our financial and our clinical and operational challenges. Going back to Chris Bird's presentation at the start about how the joint forward plan fits in, we felt it was important to be really clear, and this is again the work that the strategy directors helped us do, to say, well, things need to fall into different categories. And starting from if you're looking at that page 213, starting at the right, there are certain things which are absolutely crucial, business as usual. So for example, mental health is not mentioned in the recovery space. It's an area where we think we've got a good programme board. It works really well. It's already pan system. So it's obviously absolutely vital that we continue to deliver improvements to mental health. That fits into the business as usual area. That has the CIP, the business as usual part of the CIP applied. So all parts of the system are being asked to be more efficient to the tune of 3.44%. As I say, we've been asked to improve that, and we think we're going to do that. But that principle is that business as usual activities continue to be given that important role and to deliver efficiency improvements. Moving into the next part, we were really keen, which again is the joint forward plan, to ensure that we don't become very short term in what we do. We do need to have an eye to the future. We do need to improve services which will make a difference down the line into next year and beyond. So there will be schemes that come forward which will be transformational, that will also be undertaken. And then finally, in terms of the year that we're now in, we do need things to be put in at real pace and deliver improvements. And we've got 6 which have been forming over the last few weeks, and you've seen most of them, so I'll go through them really quickly. So continuing healthcare is, as I said, an established system collaborative already, so that's about continuing to take that forward. We set ourselves a financial target of 109 million. We've already achieved about half of that, so there's another half to go. Really importantly, it's delivering other improvements to patients' lives. So that's going to continue, and it's going to continue with a financial target. Secondly, local authorities made the point very strongly that the system priority of children and young people needs to be given full prominence, and so that's second system collaborative that we're looking to form. Thirdly, in terms of tackling the operational challenges we have in terms of the volume of work, particularly in the acute sector, the work that Lorna Clarkson and Paul Evans-Jones's team has done has identified that we have significant opportunity with the over 65s. We over hospitalise in that category, in that cohort. That is all about putting in a single point of access and working very closely with care homes and other parts in order to reduce the number of patients who come into the secondary care sector. So that won't release cash, but what it will do is ensure that we right size the system and we have the ability to live within the bed base and the physical capacity that we have within the system. Fourthly, and this was mentioned earlier too, the corporate and back office. So working collectively across the system now, rather than just working in our silos, are the things that we can do at a system level that will enable us to spend less on the back office. We think that there is. That will have a financial target. Might take some years to get that out, but we'll certainly start with that for the current year. Fifthly, medicines and clinical value. This is a really exciting collaborative actually, which has been led by Rachel Gallio and the Health and Care Senate, and it's really about putting clinicians in a place where clinicians collectively look at the types of services that we provide and put them through the test in terms of which ones have the most value. And the thing we found that really energizes clinicians is if we can make their lives better, if we can help avoid them doing things which are wasted activity. Nobody wants to do that. So empowering our clinical community to do that will lead to reduced levels of activity in areas where it's adding no value. And then lastly, contracts. We spend as a system 175 million on contracts outside of the NHS. We think that many of those could be in-housed. By in-housing them, we would certainly save money on the private sector profit that is made, but also there's some of the services that can be combined with what we provide within the NHS, clearly recognising the importance of patient choice. We're not looking to change that at all. We're looking to make the provision of services much more efficient, and that's going to be led by Helen Ashley from UHNM. So David, I'll stop there because I recognise time. Just wanted to give a bit of time just to the framework going forward. This is the route by which we will recover the system's finances, continuing to become more efficient and more productive, and then layering on top of that the system work. This is the way that we can collectively come back, and we're now going through the process of putting values against these timescales, metrics, and ultimately then working that back into a model. We don't think we can return the system to financial balance in 24-25. As I say, the system, the NHS wants us to do that. We don't think that's possible. But what we do have to do is do it over a manageable period of time. And this is the method by which we will achieve that. I'll stop there and hopefully we can take some questions.
Okay, thanks very much, Paul. Just aware of time, very full presentation. The board's taking some time to look at this in more detail later this afternoon. I'll just open it up if there are any immediate points of clarification that anybody has on anything you've heard. Julie.
I've got a couple of detailed questions, but I'll wait because there's more time later on. It is a really good model. We've proven it with the collaboration on continuing healthcare. My detailed questions can come later. I guess for me, my one question here is that's a lot of work. It's the capacity and the resource available, the headspace, the ability to work on all these at the same time that gives me some concern.
Yeah, great question. And the resourcing of this, Paul and colleagues, I know Peter's talked about making sure that there is adequate resource put behind this, because as you said, Paul, this is mission critical that we actually get through this work.
Yeah, I absolutely accept the point. Thank you, Julie. And we're working through that and we'll come back with some precise proposals very, very soon.
Thanks for the question, Julie. Okay, so with the presentation that the board has heard this afternoon, we've been asked to note the operational plan flash submission, note the timeline for our first operational plan submission, and note the progress made around the recovery plan, and note the wider, higher level planning timeline. So board happy to receive that report. Can I thank you, team, for presenting that again? A lot of work going on to get us to this position. Paul, we might as well do the entire Trinity now and move into the budget settings. So over to you, enclosure 14.
Thank you. I'll try and catch us up on some time now, because this is hopefully a matter in the sense of formality. It's been scrutinised by the Finance and Performance Committee, Megan and Josie. It reflects what I've just said in terms of the budget. It's the ICB part of that. So the system number I've mentioned, this is the ICB part of it as it currently sits. This is work in progress, David. What we need is approval today to the board so that we can continue to employ people and commit contracts week after next when the new financial year starts. But it is not a final budget because we've obviously still going through the process of agreement.
Thank you, Paul. So just pause there. I'm assuming this has been well socialised amongst members of the board. Everybody happy with the report to move to the recommendations? Thank you very much. So that is, the ICB is asked to ratify the interim budget for 24-25 financial year, following the recommendations from the Finance and Performance Committee in line with standing financial instructions, and then to approve raising purchase orders aligned to the draft budget to enable the timely payment to providers and suppliers. Does that give you sufficient for today, Paul, to move forward on?
Yes, thank you.
Okay, thank you, Paul, once again for those reports. So we'll move swiftly on, if we can, into item 15, People, Culture and Inclusion report. Mish, if I ask you just to give any escalations from the report that we've received, and then we'll take Showcat's Chair's report at enclosure 16.
Thank you. Yes, in terms of the report, I will take it as read, and in any escalations, just to say that actually from a workforce dashboard perspective, we're in a very positive position in Staffordshire and Stoke-on-Trent. Our agency performance is really good at 3.2%, and that should be noted. The target's 3.7%. So, and consequently, our vacancies have gone down and our turnover has gone down. So from a workforce position, we are very healthy at the moment within Staffs and Stoke, and what we need to do as we go forward is to continue with that from a cultural and health and wellbeing perspective, to ensure that despite our financial challenges and changes that we may have to make to become more productive, that we continue to have a healthy and well engaged workforce within our county. There are risks in the report that you've seen, particularly page 233 outlines the challenges that we face with the system. So to meet the financial challenge, but also to meet the long-term workforce plan numbers, there are some frightening figures in there. They are over 15 years. However, we do need to make sure that we continue with the widening participation work that we're doing to ensure that we have the supply coming in to our sector so that we can continue to have the workforce supply as we go. So I think culture, well-being and our OD response is massive, and we need to think about inclusion as well, to make sure that despite everything else that's going on, that we have an unapologetic focus on those things, so that we are as inclusive as we can be of our community and ensure that our workforce are fully valued. So I'll stop there, David, unless there are any questions, and I can bring, I think it might be Julie, because Showcat wasn't at the last committee meeting doing the committee report.
Okay, thanks very much, Mish. Showcat, it's a double act, it looks like, between Julie and Showcat. Or Julie, are you taking this report? Everybody's jumping in and out.
Yeah, sorry, Chair, that's me.
You can bask in each other's
reflected
glory on this enclosure, guys. So who's going to take it? Julie, over to you.
So nothing specifically to add. The committee did acknowledge the passing of Paul Draycott, which a number of tributes, which was very touching and very appropriate. We agreed to the strengthening of governance between the committee and the People Collaborative. We're working on that. There was an excellent discussion around inclusivity and also the Too Hot to Handle report. Going forward, Showcat might not have picked this up, but we've agreed that it was going to be a separate agenda item on the People and Inclusion Committee going forward. But also the one thing that I think we'd like to ask of the board is that as the board we keep a focus on inclusivity, even though we have this focus on finance and quality services. It must be in the context of inclusivity of our workforce and health inequalities as well. So that would be our ask of the board today.
Julie, thank you for that. A really important point. And just to confirm that, I think we've got a development session coming up, haven't we? That will include the Too Hot to Handle. And the expert Roger Klein is coming to one of our board development sessions, which will be fantastic to actually make sure that focus that you describe is maintained, because we are committed to do that. So thank you very much, both of you, for the escalations and updates. We'll just pause and see if anybody has any questions. It looks like you've covered those off. Thank you very much. Always good for a chair to have them covered off in the presentation. So we're being asked to note the workforce position risks and mitigations in place, and also from the committee to take assurance regarding the report submitted. So thank you very much for all the work that's going on through that committee. Item 16, the ICB constitutional changes required by NHS England. Tracy, I'm going to hand over to you, and I think Paul, just to take us through the report, which again should be pretty self-explanatory.
Thank you, Chair. And it is pretty self-explanatory, and Paul's here for any technical questions you may have. But the ICB has a legal duty to have a constitution. We utilise an NHS England template, and then we have local variation. In order to change that constitution, there's two ways. We can put a local request into NHS England, or NHS England varies the constitution. In this circumstance, NHS England have asked us to vary the constitution as per the paperwork. So I think I'll stop there, Chair. I don't know if there's any questions. It's quite clear what we've been asked to do, and that's what's within NHS England's gift to do to us. I think you're on mute, David, this time.
Yeah, thanks, Tracy. So clear report there and clear overview from Tracy. Just check, are there any issues that anybody wishes to raise? Point of clarification? No. Okay, so we approve all the mandated NHSE changes made forthwith to the Staffordshire and Stoke-on-Trent Constitution as outlined in section 2.3 of the briefing, and also approve that a letter is sent from the ICB chair alongside the updated constitution enacting the above to the NHS Regional Director Dale Bywater. Yep. Okay, thank you. Let's turn over. So Tracy, I think you're taking item 17, enclosure 18, the Freedom to Speak Up report, really important report. Hand over to you.
Thank you, Chair. And first of all, I'd like to say a huge thank you to our Freedom to Speak Up Guardians, Shabana Mahmood, and to Tracy Rebel for all their work they do as the Guardians across the ICB. So the report details, it does report through to People, Culture and Inclusion Committee on a regular basis, but we thought it was really important to bring to this board what happens through our Freedom to Speak Up Guardians on a regular basis, on a 6-monthly basis. So what the report details is the activities that have been undertaken in the past 6 months, and you can see that October was Freedom to Speak Up month, and it was a really good month where we were sort of looking at what are the barriers to people speaking up and trying to address them. You can see many things that were taking place, and there's a lot of energy behind our Guardians in the work that they do. They do detail, obviously, anonymously due to the confidentiality of the work they do, some of the caseload work that they are doing, and we do look for themes and trends within that to see if there are any issues that we need to pick up and look in more detail at. I think, Chair, in terms of time, I'll stop there unless anyone's got any questions or whether anybody else would like to mention anything.
Okay, thanks, Tracy. It's great to see this report actually coming forward. Mish, oh, sorry, Megan.
Thank you. Thanks, Tracy. So just a really minor one, but I think it's important. I've got 2 points. The first one, in terms of the authors, I think they should be down as their titles as Freedom to Speak Up Guardian, because that's capacity in which they're doing this, not their other role. I just think that's an important distinction to make, really. And then secondly, just in relation to the contacts that have been made, we've had quite a few contacts from GP practices, and it would just be helpful, I think, to have a bit more information next time regarding the nature of those contacts, because it just says contacts. Yeah. Whereas for other contacts, it gives us some more detail, so we can keep an overview of that. Thank you.
Yes, we'll do, and we aren't actually technically have to provide to GP practices, but we have done because we felt it's the right thing to do. We know that there's a situation in the north where the Federation do provide that for some of the North GP practices, but we thought it's really important that we do open that up. So it's been more of a recent thing, but it's a point well made, so I'll make sure that themes come through. At the moment it is as it is, but I will make sure they come through in future.
Yeah, thanks, Megan, and Tracy, thank you very much for the report. So we've been asked to note the paper as presented for information, and thank you, Tracy, for bringing that forward. Item 18, Julie, can I ask you to take any exceptions from enclosure 19, the audit committee report, please?
I'll take as read. Just any questions? Thanks.
Thank you very much, Julie. Any questions for Julie on the audit committee report? No, thank you, Julie, for the work that the audit committee does. The board can take assurance regarding the report provided as your recommendation, and we note that. Okay, thank you very much. That brings us to any other business. I don't think, Tracy, we've had any items of any other business notified to us in advance of the meeting. So we'll move into item 20 if we can, questions from the floor, or indeed, Tracy, anything from the chat or any other means that you've picked up from members of the general public viewing and attending the board today.
Which order would you like me to take it, Chair? Because Mr. Syme's got his hand up, and then I can go to the chat if you wish.
That's absolutely fine. Take Ian first, and then we'll go to the electronic questions.
Thank you very much, Chair.
Welcome, Ian.
Can you hear me okay?
Yes, Ian, I can hear you loud and clear.
Okay.
And welcome.
All right. Thank you very much, Chair, and thank you very much for the answers to my questions previously. I've actually had extended questions to ask, but I'd rather deal with the simpler ones and email the extended questions after the meeting, if that's okay.
Ian, that's much appreciated. Thank you for that.
Right. Regarding the specialised services, mention was made, it's two parts to this, of it being a West Midland pilot. West Midland pilots, of course, have time frames. What's the time frame for the pilot? And the second part to that question is, as an advocate, I helped an individual go through a process of appealing rejection of access to a specialised service, the individual funding request and exceptionality. We ended up in the Supreme Court over a decade ago. What is the situation with regard to exceptionality individual funding requests? Does it sit with the ICB or with the West Midland Pilot?
Thanks, Ian. So is anybody on the call? Chris, are you able to give the detail that Ian requires there? Yeah.
In part, I think, Chair. So the arrangements for individual funding requests are set out in the collaborative agreement. So Ian, if it's okay, I might just need to email you separately about that, and I'm happy to make that available to the board more generally. Yeah, David, I just can't bring those immediate arrangements to mind, but I know they are covered off in the collaborative agreement. In terms of the pilot, I think there might just be a little bit of clarification on the language there. So the delegation proposals that the board considered earlier are not a pilot. They would see the transfer of delegated commissioning responsibility to the ICB from April 2024 onwards. So unless there was a decision to revert at some future point, it's not a pilot in the sense that you trial it for a period of time before making a decision. We've effectively made the decision at board earlier to accept those delegations. Okay. There are further delegations which are planned for April 2025, which we do need to work with colleagues in NHS England on. But again, perhaps this time next year we'll be in a position where we're inviting the board to consider the acceptance of those delegations. But again, I wouldn't imagine that would be on a pilot basis.
Thank you. Quickly, it's a question on maternity services. Maternity services certainly have improved quite dramatically at Stoke, but they still need to carry on improving. I think everybody would agree with that. However, I've trawled UHDB, University Hospital Derby and Burton board papers. I've trawled the Derbyshire ICB board papers. Maternity services at the Derbyshire ICB talk about UHDB in its entirety, and not Queen's Hospital is separated, and Chesterfield Royal. UHDB do exactly the same thing. As Staffordshire women do use Queen's Hospital Burton, what's the situation with Queen's Hospital Burton?
Thank you, Ian. Heather?
Yeah, thank you, Ian. Good question. And I know we've talked about maternity services at Burton before. I think I just want to start by saying my positive statement about the UHNM services was in no way an indication of any complacency. Of course, we're not ever complacent, and we continue to work with our local providers. From a Burton point of view, I think everybody knows there's been a number of issues underlined, I think, recently by a difficult inquest which has hit the national media. We work really, really closely with the Derbyshire ICB and with the UHDB as a trust itself. And we have members of the maternity team who work in my directorate who purely focus on improving services or working with Derbyshire to improve services on the Burton site. So I'm happy to have, again, in the interest of time, I'm happy to have a more detailed conversation with you offline, but I can assure you that we work very, very closely with our colleagues in UHDB and Derby and Derbyshire ICB to make sure that the patients from Burton and Staffordshire, actually wider Staffordshire, are getting a high level of care at Burton, and where they're not, the action is being taken to address it. And apologies, I've just realised I've not come back on camera after all that.
Thank you very much.
Thank you, Heather.
Finished, and thank you, Heather. I'm trying to get rid of my hand now.
Yeah, thank you, Ian. Thank you for your interest and attendance and questions today, Ian. Thank you. Tracy, can we take any other questions that we've received either through the chat or email while we've been conducting the meeting?
Yes, a lady called Amanda Gris has put 3 in the chat, but 2 are on the same subject. So I'll take those 2 first. So her first question is, I understand the contract to Opcare for recommissioning of the orthotic service to one single provider is worth 13 million. How much money has this saved you compared to previously using the 3 providers for South Stafford and Stoke-on-Trent? And then her further question was, why has the orthotic service previously provided by the 3 NHS providers now be recommissioned to a private company? So I think those two go together, Chair.
Thank you, Tracy, and thank you for the question. Phil, you've popped up, so I'm assuming you've got the answer to that question or those questions.
Yeah, thank you. Thanks, Chair. And thank you for the questions. I'm afraid I don't have all of the contract detail to hand, but what I can tell you is that we went through a full procurement process last year, and OpCare have previously been the provider in the north of our patch. And they'll now move to be the provider also in the southeast and the southwest. But as I say, I don't have all of that detail to hand, so I'm happy to write back separately with the specifics around it.
That's great. And Tracy, if we can just make sure that the answer to those questions is available to the broader audience or who've attended today. Okay, so back to you, Chris.
Sorry, David, if I may, I've just had a quick look at the delegation agreement that we considered earlier, so I am able to answer Ian's earlier question down around individual funding requests. So it is section 14 of the delegation agreement that's in the public board pack and confirms that the ICB will provide support to NHS England in respect of determining individual funding requests, and then the ICB will implement that decision. So it sounds like it's going to be retained by NHS England as part of their commissioning, centralised commissioning support, and the ICB will support that process.
Thanks for that, Chris, and hopefully in that covers off that query for you. Tracy, if just go back to the chat, further questions or comments?
Yeah, so Amanda's obviously registered with us today, so I will make sure that the question answer gets back to her. She also said, when will you start consulting with patients and public with recommissioning of services? And as you know, there's an ongoing responsibility for us to work with patients and public. If there's any issue in respect of a single contract, then we'll get back to her within that. But we have our duty. We work through our People and Communities Assembly. We work the VCSE sector, and we work through our quality impact assessments, all that require patient public engagement. We have Health Watch represented on our boards today. So that's the generic. If there's anything in particular Amanda wants to, I will check that question out after, just with the theme coming through on those questions.
Thanks,
and then
Tracy.
There was a further one from David Jones, and it's a question to the board re intelligence strategy. In the 1960s at the North Staffs Royal Infirmary, a project got underway to provide what we could call computerised healthcare based on a national vision of electronic integration, or using today's terminology, this could be an intelligence strategy. After 60 plus years, we have a lot of tools, but no comprehensive electronic integration. I don't see this changing as our aspirations and emerging technologies change. We ought to be investing as much as possible in applications of systems which provide direct patient benefit. You may even call this piecemeal application, and yet make sure that these appropriately integrate as necessary based on technology available at the time. All I ask is that when the ICB is looking at the emerging intelligence strategy, they bear in mind these points.
Okay, thank you, David, for raising those points. Chris, quite a big question there.
It is a big question, David. Thank you very much for raising it. And I'm somewhat optimistic in this regard, because what I didn't talk about today to the board was we are right in the middle of quite an extensive electronic patient record business case, which is underway. I think I talked about it on a previous session. And that work will be concluding towards the latter part of this calendar year, which will provide significant improvements and simplification of how we manage patient records across Staffordshire and Stoke-on-Trent, across all of our key stakeholders, which would be a significant improvement moving forward. Related to that, we also have deployed across our three key providers a product which enables sort of improvements in patient interaction. The product itself is called Patients Know Best. You might see that when you log into the NHS app, you might see powered by Patients Know Best. And this starts to provide much improved interaction from our residents directly with their healthcare information. So I think that there are significant improvements, and the point that you make around integration, interoperability are very important. But equally, you know, we have hundreds of IT systems, and we're working very actively to try to simplify that and reduce that down to make it more accessible directly for our patients. I hope that it was a long question, but I hope that goes some way to answering it.
Thanks, Chris, and thank you, David, for the question. Tracy, does that conclude the questions and comments that we've had?
Yeah, Baz has just put in about orthotic service contract, travel times to receive services. I think we'll pick that up outside. There is some, I have seen that there are some FAQs around the service change and everything in a stakeholder briefing that I'll make sure Baz has got sight of. So.
Yeah, thanks, Baz, for the point. We'll pick that up as Tracy defines. So all good, Tracy. All clear from any questions. Okay, thank you very much, and thank you to everybody for raising those important questions with the board today. Just in terms of meeting effectiveness, it's been a very full-on busy meeting with a lot of very important items covered. Just want to check that everybody's had ample opportunity to ask any questions or raise any risks or other issues that board members have wished to raise today. If not, please let me know. Just moving into the compact that we talked about at the start, just want to check that we have adhered to the components of our contract and compact, and everybody is content with that. Thank you. So we'll bring the meeting to a close at that point, slightly over. The next session of the board for board members, I suggest we commence around 2:50, just to give people time to stretch their legs and get a drink. And we'll bring the meeting to a close at that point. The date and time of our next meeting, which will be again by Teams, will be the 18th of April at 1 o'clock. So thank you, everybody, for your contributions this afternoon. We'll bring the meeting to a close at that point.
Thanks, David. Thank you, everybody.
Thank you. Bye-bye.
Bye.
Thank you.